I think we're going now to Bucharest. I'm going to invite a surgeon, a complex one, who operates from the anterior pole and now has her attention on the posterior pole. It's about Dr. Rosana Moraru from the Oculus Clinic, who was kind enough to share her knowledge and experience with us. Dr. Moraru, thank you.
Thank you so much. I'm trying to, do you see my presentation, please? Do you see it? Can you hear me?
Yes, clearly.
Yes.
Okay, do you see my presentation?
Yes.
I hear it on the screen. Is it there?
Yes.
Yes.
Okay. Thank you. Let me put this. Okay. First of all, thank you. First of all, I'm going to present in English, although Katarina told me a few days ago that I should present in Romania, but I saw that my famous former presenters presented in English. I will do so. Thank you for having invited me here. I'm going to present some cases, two cases, which are similar, quite similar. So, both of them are male, 39 and 38 years old male. Both of them had congenital cataract with surgery several years ago. The one in the left-hand side has been operated in 1997 in another clinic with PCIOL. He developed RD, he had surgery, but now he came to us with no light perception. And the other eye was operated in Oculus by me in 2002. It was an unvetted phaco with PCIOL, everything went okay. And after 20 years, after 19 years, last year as a matter of fact, he came with dropped visual acuity starting 1 month ago. And we diagnosed him as rheumatogenic retinal detachment with macula off. On 31st of August 2021, he had the surgery for this retinal detachment. The other guy is, again, a 38-year-old male with congenital cataract operated when he was a young child, 1984, again, first without IOL, and then when he was 9 years old, he received in both eyes anterior chamber IOL in another clinic. He also had and has strabismus and nystagmus. He came to us in March, April this year with bullous keratopathy in right eye and very weak visual acuity, count fingers, and in the left eye, his only good eye. He experienced a drop to 1.1 of the visual acuity, and we diagnosed him as having inferior RD with macula off. And of course some changes in the anterior segment, which you will gonna see when I present the pictures. So this is the first case, a very nice anterior segment, a very nice position PCIOL, and his detachment, visual acuity hand movement. Of course the macula was completely covered, and this is the video. I'm gonna leave it to just go. I'm performing, this is my standard technique, and what you see in the right hand side in yellow, it's standard technique. What is added in white, it's there are steps of the surgery which I don't perform in all cases, so they are not standard. So these were the steps of the surgery for trocars of 25 gauge, chandelier light, core vitrectomy. In this case I used fluorescein for staining better the vitreous, and it helped me indeed in cleaning the vitreous. While I'm performing the core vitrectomy, I also used to use the external light because it highlights me the vitreous close to the tip of the light. And then I inject, after I checked the PVD, with or without triamcinolone, in this case I didn't need triamcinolone, I injected perfluorocarbon, and then I performed shaving on 360 degrees. I am checking for the breaks. I saw one at 6 o'clock, and it will be another one at 12, more or less at 12 o'clock. And after I shave 360 degrees and checking all the breaks, then I inject more PFCL. I go higher with the level of the PFCL and perform the shaving once again. Also it's time consuming, but I do it once again in more anterior part of the retina. And I am more sure that I checked completely the possible small breaks which I might miss. So you see I'm using 10,000 cuts. And I'm very careful in removing as much as possible of the peripheral vitreous. I will go a bit farther because now it is time consuming, as I just mentioned. And under PFCL I put the laser spots around the two breaks that I found in this case. And the next step, you can see here in the right hand side the steps of the surgery, and the next step is the fax, injection of the air while I'm aspirating the BSS lamella between the air bubble and the PFCL down, the air bubble up and the PFCL down, and I'm aspirating. It's very important to aspirate until you just don't see anymore the water meniscus, let's say. And at the end, of course, I aspirate the PFCL from the bottom of the fundus, of the vitreous cavity. And in this case, I injected 1000 centistokes silicone oil, just to be sure, because it's a single eye patient and you really want to be sure about its good tamponade and stability. The visual acuity recovered on the silicone very quickly and very nice, 0.5, 0.6, and 1 year after the surgery he develops this lateral to the fovea, this membrane which decreased the visual acuity to 0.3, and most probably we will operate this membrane. This is the second case. This is the right eye, bullous keratopathy and strange shape of anterior chamber IOL, which was at that time. And this is the left eye, his good eye, with nystagmus, who came with retinal detachment. And at visual acuity was 0.1. At the specular microscopy showed us some cells, but were not measurable, with some lacuna, some empty spaces, and poor contour of the cells. We decided, of course, for the surgery. Again, I'm going to pass a little bit faster the video, but in this case, as you saw, the anterior chamber IOL the pupil was deformed, horizontally deformed, and the anterior chamber IOL was cutting, let's say, the middle of the visual axis and of the pupil. So you can see how difficult it was for me to good visualize the retina, because the IOL is interfering in my visualization. So this is the haptic, this is the margin of the optic. And in certain points of the surgery, you will see that it's really annoying to see both through the IOL and next to the IOL. In this case, I used triamcinolone in order to be sure that the PVD is completely detached. I localized a lot of breaks, as a matter of fact. In this case, this bigger one, one small here, and there are two other small here, and you will also see in all the temporal area and superior up to here several breaks. Of course, the goal is to, after I injected PFCL, the goal is to shave very well the peripheral vitreous, especially around the breaks, but all around 360 degrees is preferable, which I did. I aspirated the subretinal fluid, and again I'm very careful in performing a good another break here, a good shaving. I'm using again the Constellation machine, Ingenuity 3D visualization system with 10,000 cut rate. Again, this is a smaller break, and other breaks here you can see them. I'm gonna go a bit it's covered. Let me see. Okay. Another break here. So again, I need to be very, very careful in this case with so many breaks. Again, I'm talking about a single eye patient. In this case, maybe you didn't notice, it was very fast forwarded at the beginning. I used 3 25 gauge trocars and 1 23 gauge, because I planned to inject the silicone oil of 5,000 centistokes. It is said that it doesn't emulsify so early, and as the other one, the silicone 1000, so I assume in this case maybe I should need a longer tamponade, and that's why I had in plan to inject 5700. I'm gonna go a little bit faster. Again, look how annoying is this IOL. Apart from the fact that the pupil is not dilated, this is his maximum dilation, look how annoying is this IOL entering in my visual field. I'm shaving both through the IOL and besides near the IOL. So again, it's quite difficult it's taking more time, and you need to be very careful. Again, shaving 360 degrees, some remnants anterior. After I injected more PFCL, I also shave more anterior vitreous. Again, I have the IOL in my visual field. Under PFCL, I put laser around all the breaks. And I finished by doing almost 360 degrees laser application, inferior, temporal, and superior. Only a small part of the nasal retina was not, again, laser here. And I'm gonna go a bit further because laser is more or less the same. Fax, which is a very important step of the surgery. You want to avoid entering the BSS under retina, so you need to be very careful when you perform. This is what I learned, and it is so. Aspirating the remaining PFCL. This is one of the issues when you have communication between the posterior chamber and anterior chamber. You have air in the anterior chamber. And more than that, even if you do tamponade with air or gas, you can have it in the anterior chamber. If you do tamponade with silicone, you can have it in the anterior chamber. It's annoying for the visualization, but it's also dangerous. You don't want to have them in the anterior chamber. And the second, at the end of the surgery, my goal was initially to explant this anterior chamber IOL, which might be dangerous for the cornea. But I tried to do it. The haptics were so very deep in the iris. I managed to explant from the iris only the right hand side haptic, with the cost of an unwanted peripheral iridotomy, but this could be managed. But unfortunately, the right hand haptic was really impossible to be withdrawn. So I just leave it there. I check once again the fundus, the optic nerve aspect, the IOL, the IOP, the pressure, and I removed the trocar. So that was the surgery. This is how the eye looked in September 2021. Retina attached, visual acuity was relatively good, let's say, but the diopter was changing, and I assumed it was because the patient looked either through the lens or besides the lens. So we will see what we will do. My intention was to explant the lens and leave the patient fake. You can see in further on when maybe I remove the silicone oil to see what is to be done with the anterior chamber with the secondary implantation. This is the post-op OCT, very nice, and this is the anterior segment OCT, which showed me this area where the haptic is still embedded in deep stuck in the iris. I have closed angle, but I will see what I will do with this case. As a matter of fact, this is what we need to do to see how we are going to do, what we are going to do with this anterior chamber IOL. We had, this patient had recent US removal 2 weeks ago. I had a nice surprise because I measured again the endothelial cells, and not so that they just appeared from nowhere, but the problem is that the first measurement was not well done due to his nystagmus. Now we received the second, we catch a second when the nystagmus was not there, and we managed to count quite a nice endothelial cell numbers. So we decided to keep the anterior chamber IOL in place, and the discussion will follow if this centered IOL will influence his visual acuity. If it is so, we will remove it and put another PC IOL at this time, fixed at sclera. But if it doesn't influence the visual acuity, we will just monitor this patient with further endothelial and intraocular pressure control. As a conclusion, anterior segment really matters in posterior segment surgery. You saw two similar cases, but with two type of, also the surgery is the same as steps and as standard procedure, let's say, at least for me. I encountered different problems during the surgery. The communication between the anterior posterior chamber can be challenging due to air migration, silicone oil migration, and so on. And of course, the IOP rise in this young patient can be quite common. Thank you very much.